Welcome to the explainer. Okay, so you've got a patient with chest pain. What do? Do you order a stress test, a CT scan? Today, we're going to build a mental framework, a way of thinking that will help you answer that exact question and choose the right cardiac diagnostic test for any patient every single time. I mean, this is the fundamental question we face every single day, right? And our goal here is to move way beyond just memorizing a list of tests and instead move toward a really logical, patient-centered approach. Okay, let's dive in. So here's our roadmap. We're going to start with the absolute foundation of any workup. Then we'll walk through the three big clinical scenarios you'll see all the time: chest pain, murmurs, and palpitations. And we'll wrap it all up with a really crucial look at patient safety and the risks of all this testing. Right. Before you even think about ordering an echo or a stress test, just remember the most powerful diagnostic tools you have are right in front of you: a careful history and a thorough physical exam. Seriously, this is where it all begins. This concept, pretest probability, is absolutely central to cardiology. It's the engine that drives our entire diagnostic strategy. You know, a 25-year-old with some fleeting chest pain has a way lower pretest probability of coronary artery disease than a 65-year-old with classic crushing chest pain. Getting this right helps us avoid a ton of unnecessary and sometimes even harmful testing. Okay, let's tackle the big one. Your patient comes in with chest pain. You've got this huge menu of tests to choose from. So how do we think through this logically and figure out the right way to investigate for potential coronary artery disease? So here's the crucial point. For your low-risk patients, that young person with atypical pain, you actually risk getting a false positive, which just kicks off this whole cascade of more tests. For your really high-risk patients, you should probably be thinking about going straight to an invasive angiogram. It's that intermediate zone, that's the sweet spot where stress testing really shines. So, this is our first major decision point. This is the fork in the road. We have to figure out what question we're trying to answer. Are we looking for evidence that blood flow is actually limited right now? That's a functional question. Or do we just need to see the arteries themselves and look for plaque? That's an anatomic question. Two different questions, two different paths. And this is brilliant. It perfectly illustrates why stress imaging is so sensitive. Think about it like a line of dominoes. The very first thing that happens is the heart muscle stops getting enough blood. That causes changes in perfusion and how the wall moves. Then, way later, the electrical activity changes, and only at the very end of this chain does the patient actually feel chest pain. Imaging catches the problem at the very beginning of the cascade, long before the ECG changes or the patient feels a single thing. Okay, so how do you actually choose? Well, what's really cool about this slide is how it kind of simplifies the whole thing. If your patient can exercise and their baseline ECG is clean, a simple exercise ECG is a fantastic first step. Plus, it gives you all this powerful prognostic data. But if they can't exercise, or if their baseline ECG has something weird on it, like a left bundle branch block, then you move on to imaging. Simple as that. Okay, so let's build on that. What if we decide we do need to see the arteries themselves? Well, we have some incredibly powerful tools at our disposal, both non-invasive and invasive. The big PROMISE trial really put CTA on the map for a lot of us. It basically showed that for patients with an intermediate risk of CAD, starting with a CTA was just as safe as starting with functional testing. And get this, it actually led to fewer invasive procedures down the line. So it's a really reasonable choice. A calcium score, or CAC score, it gives us this snapshot of the total plaque burden that's built up over a person's lifetime. Now, a score over 400, yeah, that's considered severe. But you know what? The most important number on that report might actually be 0. A CAC score of 0 is associated with a very low risk of future heart attacks or strokes. Oh my man, this is a total game changer. FFR helps us understand not just where the blockages are, but how much they're actually affecting blood flow. It's the difference between seeing a traffic jam and knowing if it's actually stopping cars from getting through. This helps us decide which blockages truly need a stent. All right, let's switch gears. We've been talking about the pipes, the coronary arteries. Now let's talk about the pump itself and the valves. What about the patient with a brand new murmur or someone who's short of breath and you're thinking heart failure? Well, here our primary tools are all ultrasound-based, and they are absolutely essential. For the vast majority of structural questions, the TTE is your go-to. It's your workhorse. It's non-invasive, and it gives us all this essential info about how the heart is squeezing, what the valves are doing, and even the pressures inside the heart. But what if we need a much higher definition view, especially for things in the back of the heart, like the mitral valve or the left atrial appendage? That's when we turn to the TEE. By putting the probe right down the esophagus, we get this absolutely unparalleled, crystal clear picture. And now for our third big clinical scenario, the electrical system. A patient comes in, they're complaining of palpitations, feeling dizzy, maybe even passing out. Now, unlike a leaky valve that we can just see on an echo, these symptoms can be super fleeting. The whole challenge here is catching the event in the act. So our choice of test depends completely on how often the symptoms are happening.
Always, always, always start here. Even when the patient feels totally fine sitting in your office, the 12-lead ECG can give you these crucial underlying clues, things like pre-excitation, which is an extra electrical pathway, or conduction delays that can slow the heart way down. It can even show signs of underlying structural problems.
And this table is basically your cheat sheet. It's a really logical progression. If symptoms are happening every day, a 24-hour Holter monitor is probably enough. If they're once a week, you need a longer monitor. If it's once a month or even less, you need to be monitoring for months or even years. The more fleeting the symptom, the longer you have to look for it. And finally, this is such a critical part of our job and of shared decision-making. We have to understand and we have to communicate that every single test we order has some degree of risk. No test is free. So you see this number, 1 in 2,500. And yeah, that risk is really small, for sure, but it's not zero. And this is exactly why we have to have a clear reason, a solid pretest probability, before we send anyone for any kind of stress test. And for pharmacologic testing, listen, knowing these absolute contraindications is a core patient safety skill. You just have to know this stuff cold. Using vasodilator agents like adenosine or regadisone in these specific patients can be incredibly dangerous. And that really brings us to the most crucial takeaway of this whole explainer. Thoughtful, appropriate testing, the kind that's guided by a good history, a good physical, and your estimate of pretest probability. It's not just good medicine. It's about protecting our patients from this cascade of unnecessary, expensive, and potentially harmful procedures. We're already seeing this massive shift from invasive to non-invasive ways to diagnose people. And it leaves us with this really fascinating question about what cardiology is going to look like in the future. What do you think the role of the cath lab will be in, say, 10 or 20 years? It's something to think about.